And ladies and gentlemen, the next topic is also very important because we will be proceeding to what is happening right now in Singapore, because we have the representative who is actually representing Tock Seng Hospital, the hospital that has a really strong root in the community for more than 175 years, as well as has been recognized as the People's Hospital and been serving a resident population of more than 1.4 million living in the central Singapore. At the same time, because this hospital is actually one of the largest multidisciplinary hospital in Singapore, that is the reason why we can learn a lot from its clinical implementation of pharmacogenetics in this very hospital. Ladies and gentlemen, it's time to give it up to Dr. Goh Ling from Tock Seng Hospital.
Good afternoon, and I'd like to thank the organizers for the invitation. I'm Ling from the Tock Seng Hospital. I'm a scientist that oversees the clinical testing and research activities of Molecular Diagnostic Lab. I'm also a member of the Pharmacogenomics work group in our institution, and I'm very happy to share our experiences in implementing pharmacogenetics for clinical care. Start the presentation, I'd like to share briefly about our hospital. It is one of the largest multidisciplinary acute hospitals in Singapore, with more than 170 years of history, and it is named after its founder, Mr. Tock Seng. The Ministry of Health has organized our healthcare system into 3 clusters. Tock Seng Hospital is a member of the National Health Group that manages the population health in the Central Zone. Our institution recognizes that personalized medicine is playing an increasingly important role in clinical practice. Therefore, the service was established in 2015 to provide genetic testing and individualized treatment. Our service has 3 focus areas. Number 1, clinical genomics that uses genomics for diagnosis, prognosis, and therapy management. It's mostly used by the oncologists, but we are also expanding into other areas including complex chronic diseases. The second area is pharmacogenomics that uses genetic information to guide drug selection. And the last area is on rare disorders that employs genomics to diagnose patients suffering from diseases with no definite diagnosis using conventional tests. This is the overview of today's presentation. I'll be sharing some examples to illustrate our implementation efforts, achievements, enablers, challenges faced, and lessons learned. When we started this in 2015, pharmacogenetic testing is not required as standard of care in the local context, except for HLA-B *1502 testing for carbamazepine. To succeed, we need a plan. The initial deployment should focus on the near guarantee success. Therefore, we seek institutional leadership support. We get like-minded people from different disciplines to work together. We have to ensure that the model is feasible and accepted by the medical community. Therefore, the implementation should make workflows as easy as the current state. We need enablers like education, informatics tools, and clinical decision support tools. To do more with less, we started small and we leverage on what has already been built so that we optimize our resources. And we focus on what is clinically relevant and easily implemented drug gene pairs. This slide shows our PGX implementation journey. So it started in 2015. We have a work group comprised of clinicians, pharmacists, IT colleagues, as well as scientists. So this work group provides a forum for discussion to support the adoption of best pharmacogenetics practices within the institution, and it works closely with other committees. In 2016, we prioritize the drug gene rules for implementation and decide on the testing platform. In 2017, our laboratory goes for CAP accreditation, and we make the test available and orderable in our electronic system. To get buy-in, in 2018, we embarked on translational projects and education. In 2019, we run a pilot for PGX Consult Clinic. And this year, as well as next year, we will be focusing on building tools that will enable preemptive pharmacogenetics testing. I would like to use the example of TPMT and UDT15 testing for thiopurine as an example to share the process of implementation. The process involves 3 key stages: the pre-implementation stage, the development stage, as well as the implementation stage. This slide shows the selection criteria for drug gene pass rules for implementation. We consider the model from successful centers like Mayo Clinic and Vanderbilt Medical Center. We will evaluate the scientific evidence of the drug gene pairs from databases such as PharmGKB, as well as CPIC and scientific literatures. Other considerations including the drug usage in our institution, the event rate, and whether alternative therapy is available. Back in 2016, most centers are just testing TPMT genetic variants for thiopurines. NUDT15 caught our attention. At that time, there was a couple of papers that indicate that this is the gene that is more relevant for thiopurine toxicity in Asians. We have a level 1B evidence in PharmGKB, but there was no CPIC guidelines at that time. Now this is relevant for patients with IBD and ALL. Next, we look at the prevalence for NUDT15 STAR3 variant from the public databases such as CPIC and Genome AD, which show that it is more prevalent in East Asian compared to TPMT, which is more common in Caucasians. We then validate the data in our local biobank consists of Chinese, Malay and Indian. Indeed, NUDT15 STAR3 has a higher allele frequency of 9.61% compared to 2.68% in TPMT. However, our data also shows that TPMT is not that uncommon in our population. It is higher than what is reported in the East Asian or public databases. Hence, we decided to include both genes in the PGX panel for thiopurines. There are several practical considerations that we need to consider when we set up a test for clinical use in the laboratory. We have to consider our resources. In this case, what we already have are real-time PCR equipment. We need to train our staff in performing the test, to interpret the results, to troubleshoot, as well as to handle inquiries. We have to consider the hands-on time, whether the assay is scalable, can it go for automation? We have to consider the turnaround time, which is guided by the urgency of the clinical management, and how that affects our other workflows in the laboratory. We have to ensure we have the appropriate positive and negative controls. Do we have clinical samples for validation? In terms of reporting, are we able to automate the analysis? We have to come up with standardized reporting format and how to integrate that results with our lab information system. We have to participate in quality assurance program to ensure that our assay is accurate and reproducible, and that means we have to enroll in proficiency testing program. And lastly, we have to consider how we're going to market the test through talks, brochures, and also to work out our test request route. In 2017, the test is officially launched, so we make it available in the ordering system for external clients that can use our hard copy request form. And we have been participating in the CAP-EQA since 2016, and we have been doing well so far. And in 2021, NUDT15 will be added in the program as well. After implementation, there are a few outcome measures that we can evaluate to give us a sense of how we are doing. For example, we can evaluate the testing adoption, what is the practice setting where order is originated, how many tests do we have in-house versus private, inpatient versus outpatient, and the test volume. So the diagram on the left shows that most of the orders are coming from gastroenterology department as well as neurology. And in terms of volume, we can see that the uptake increases since 2019. We have a 50% growth compared to 2018, and it continues to grow this year despite the COVID situation. We see another 15% growth. We also evaluate the quality of our service by monitoring the turnaround time. As you can see on the graph, our TAT has actually improved over the years. Back in 2017, most of the reports took about 3 working days to issue. But in this year, we can see that most of the reports, in fact 100% of them, are issued within 2 working days. So besides TAT, we also monitor genotype distribution by haplotype, the proportion of tested patients with actionable genotypes, as well as adherence to recommendation based on genotype. So on the graph, you can see the NUDT15 and TPMT phenotypes. About 16% of the patients tested are intermediate metabolizer based on NUDT15, and about 1% are poor metabolizer. You can also see that about 8% of them are TPMT intermediate metabolizers. I think we are quite successful in the implementation of NUDT15 testing. These are due to several factors. We are able to get institutional support to go for CAP accreditation, so that helps us in launching the clinical test. We engage the HODs from the relevant departments. We're able to integrate the test ordering and reporting into routine practice. And because the drug gene pair shows strong scientific evidence, we didn't really need much education when we launched the test. And I think it's also important that we use a genotyping technology that is fast, cost-effective and adaptable, meaning with new evidence we can revise the assay rather quickly. This slide is to show you the various drug gene pairs currently available in our institution. Next, I would like to share a clinical case with regards to CYP2C19 testing for clopidogrel or Plavix. This test is most applicable to ACE or PCI patients. According to the FDA-approved label, it alerts that CYP2C19 poor metabolizers may have diminished effectiveness of the drug as compared to patients with normal CYP2C19 function. Tests are available to identify a patient's CYP2C19 genotype and can be used as an aid in determining therapeutic strategy. We observed that most of the ordering physicians are neurologists instead of cardiologists. This is a stroke patient that was tested CYP2C19 star 1 star 2, and she's allergic to aspirin. Now the recommendation is that this individual is predicted to have intermediate CYP2C19 activity. Choose an alternative agent that is not dependent on CYP2C19 metabolism when prescribing clopidogrel. What would be your management plan? Would you increase the dosage? If so, what dosage is appropriate? DDWG recommends to choose an alternative drug or double the dose for CYP2C19 intermediate metabolizers who are undergoing PCI, stroke or TIA. However, it is important to note that the recommendation for doubling of dose is based on clinical outcome studies for cardiovascular indications. And how do you monitor the efficiency of doubling the dose? Measuring drug level is challenging, and the active metabolite to be monitored is P2RY12, and I don't think this test is currently available in Singapore. Or would you consider to switch to ticagrelor for stroke risk prevention? I think there's a clinical trial going on, but the outcomes is to be evaluated in larger scale trials. My take is that there's no reason to suspect that CYP2C19 variant alleles would affect Tarvik's metabolism differently in stroke patients. However, there's insufficient data for dose adjustment. It is premature to support an increased dosing strategy based on CYP2C19 genotype. We have to tell the clinician that PGX result is not a straightforward yes or no, right? The test is indicated for PCI or A. The clinician has to make the call at the end of the day. But this also gives us an opportunity to conduct a retrospective study, since we have genotyped quite a number of stroke patients, and we are actually interested to look at their outcomes and how the doctors or the neurologists act in the result. Next example that I would like to share is on our experiences with the use of multi-genes panel for pharmacogenomics testing. I personally believe that panel testing is the way to go because it reduces cost and turnaround time. Currently, most of our clinical tests are single gene for reactive testing, meaning the doctor orders a test when he prescribes a drug and then orders another test when he prescribes another drug. Moving forward, the model that we favor for PGX implementation is preemptive testing, meaning that the patient are tested on a multi-gene panel prior to prescription. Upon prescription, that gene information will already be available in the system, and the doctor is able to read the result directly from the electronic medical system. However, we are not ready for preemptive testing due to current EMR constraints, but this is something that we are actively working on. What we have today is a reactive testing model on a multi-gene panel that we call just in time and just in case. This is how it works. For example, when a doctor orders CYP2D6 testing, we will test it on the multi-gene panel. When the patient needs another test in future, say CYP2C19, we can pull out the test result in real time so that the patient do not have to draw the blood again or have the test done again. We also did a cost comparison. If we were to run 3 single gene tests, it's actually more expensive than running a panel test. This is the pharmacogenomics panel that we currently have it in-house. It consists of 27 genes, and it focuses on commonly prescribed drugs with Pharmacogenomics Association. The drug lists selected are based on our institution usage as well as the level of evidence. And the guidelines that we use for reporting are based on CPIC, APWG and FDA labels. How do we use the pharmacogenomics panel? We believe that it will be beneficial for patients who are not responding to or experiencing toxicity from an existing drug. As with all tests, pharmacogenomic testing should be reserved for patients in whom test results will provide clinically meaningful information. When determining whether an individual patient may be a candidate for preemptive pharmacogenomic testing, the provider should consider the patient's disease conditions, current medications and medications likely to be prescribed in future, whether the patient is taking multiple medications, and whether there are comorbid conditions that might complicate drug therapy selection or dosing. We face several challenges with panel testing. For example, the limitation in our LIS system. Now, reporting one gene is very different from reporting multiple genes. Currently, we can only generate and upload a PDF report, which is not very interactive. For sustainability, We need a solution for cloud-based analysis and automated reporting. I mentioned earlier that we are not ready for preemptive genotyping because of the constraint in our EMR. Because we are changing to EPIC, this gives us an opportunity to work with the team to build alerts and CDS in the EMR system. We also need to get buy-ins from our clinicians and patients. And because of all these challenges, I have opportunities to work on areas other than developing assays in the laboratory. For example, I get to evaluate digital tools, I get to work on PGX implementation projects, and I get to conduct educational courses or workshops for our healthcare workers. I will share a bit more in the next few slides. To streamline our workflow for analysis and reporting, we collaborate with a commercial company to develop PGX-guided CDS that is optimized for the Asian population and to enable easy access and continuous update of PGX information for both clinicians and patients. So as shown in this diagram, once the result is generated from the equipment, we can upload it into the system that will auto-generate the reports for the clinician as well as to the patient through the phone app. Here is a snapshot of the mobile app viewed by the patient. So the patient will be able to see the gene tested, the test results, the phenotypes, and the drugs affected. There's a search function by drug category, and there's also a section on educational frequently asked questions. What I like, but not shown here, is the feature on drug interaction checker. This is something that we are still working on and hopefully put in use soon. For the new EMR, my colleague is working on the best practice advisory in EPIC to fire PGX warnings and recommendations if positive results available in the system. Alternatively is to fire alert with pop-up to prompt test order for medications with strong PGX association evidence if the patient has not been tested. The table shows the list of drug genes prioritized for BPA in EPIC. One of our strategies to get buy-in from clinicians is to get them to work with us on proof of concept, implementation or translational projects. Co-develop the test with them. If they will co-develop the test with us, they are more likely to use it. The areas that we have worked with them includes cardiology, pain management, as well as oncology. For the pharmacies, we have put up 20 drug gene rules with CDS in their notice board, which is available in our intranet. For education, we have been conducting seminars and workshops. We find that it's most useful when we have users to share their experiences on how pharmacogenetic tests can be used for patient management. For workshops, our content include on basic genetics and results interpretation. In one of the workshops, we actually offer personal genotyping for the participants. So this gives them the opportunity to experience the test for themselves as well as to provide feedback for our report. These were the survey's findings from one of the workshops. We find that most of the participants are satisfied with the content of the report. One of the feedback that we received is that the report is too lengthy, and we have actually cut it down from 10 pages to 4 pages. Most of them will use the report to guide treatment. In terms of the drug list covered, some preferred to have a very short list with drugs that show very strong evidence, whereas some preferred to have a longer drug list. The survey also helped us to understand the aspects that will increase the use of pharmacogenetic testing. So this includes clearer guidelines about the use of pharmacogenomics, greater level of evidence about its clinical validity and utility, as well as cost-effectiveness analysis on the use of pharmacogenomics. Besides education for our healthcare colleagues, we also come up with educational material for the public. So this gives you a snapshot of what is covered in the pamphlet for the public. We realized that it is important to have a platform to explain the pharmacogenomics results to the patient. Hence, we performed a pilot in 2019 to test the feasibility for preemptive panel testing and to return the results to the participant through a counseling service. So as shown in the picture here, about 10 patients were recruited at a community event. They were offered panel testing, which is performed in our laboratory, and the results are returned to them with a complimentary counseling session at our health enrichment center. So they gave us an opportunity to evaluate the feasibility as well as to work out the logistics to set up a PGX consult clinic. For an impactful precision medicine, more work needs to be done. At the institutional level, we are currently making a video for patients. We are working on the PGX consult clinic as well as the e-consult service. My colleague is working on clinical decision support tools and reporting systems. And we are also considering whether we need a therapeutic drug monitoring to complement our service. At the National Health Group cluster level, we are planning educational programs to continue to educate our healthcare colleagues, as well as technology enhancement so that we can have a secure IT infrastructure and analytics across the healthcare system. We are open to collaborations. We believe that research will drive better healthcare. We are open to work with academic institutions, biotech companies, as well as innovative digital solution providers. Just a final note on the lessons learned. The implementation of pharmacogenomics takes a village. It needs a dedicated team and robust infrastructure. We must be prepared to work with different processes within the healthcare system, and IT takes time. We started small based on our resources. We try to integrate pharmacogenomics into existing workflow of the institution. It is important to capture outcomes and KPI indicators. And to get buy-in, collaboration, education, and awareness are key. And it is important to keep up with literature and databases updates. Lastly, I'd like to thank my team from the Molecular Diagnostic Laboratory, as well as the various collaborators who have worked with us.
Thank you very much, Dr. Ling. With the humble conclusion and summary that you have left with us, that you are trying right now at this very moment, you and your team trying with the implementation with in a very small initial step according to your resources. That very humble, but I do believe that the regional corporation must be able to assist with this implementation plans a lot with under the TTSH. Am I right? That is the first question from our audience today, Dr. Ling.
Hi. I think the CFARM itself is a very useful platform. The regional can work together in terms of knowledge and data sharing, perhaps like new discovery, new association, or even technological improvement, how we can be more accurate in our testing, or even the allele frequency in different populations can be useful to us as well, because Singapore is actually quite mixed, although we have the three major ethnic groups. So I think this information will be very useful. Another area I think we can benefit is from clinical guidelines developed. So this has been quite a challenging area. So if we can learn more from the rest, how how they develop their clinical guidelines, we don't have to start from scratch. We can actually work on that together. And if there are cost effectiveness data to be shared, I think that will be very useful as well.
Thank you very much. And we also have the last question for you, which is very interesting. The question is, how can the results or preemptive testing be returned to the EHR to support the future timely clinical decision making based on evolving PGX knowledge or the pharmacogenomics knowledge.
I shared earlier that my colleague, actually have a team of colleagues working on building the BPA or best practice advisory in the new electronic medical record system. So we have actually prioritized a list of drug gene rules with strong evidence to be built first. So if the genetic result is available, it should be, the alert should come out real time. If not, then there will be an alert to recommend for testing. So that's my understanding how it will work in the new EMR system.